The first speaker tonight is Iain Henderson, who's going to talk about triaging ophthalmic patients. He was rather alarmed when asked to do this in sort of 12 minutes, because he usually does this as a whole day course. He's an advanced nurse practitioner working in a busy A&E department in London now, but he has worked in departments all over the southeast of England. And I look forward to hear what he tells us. Thank you, Iain.
Hello, my name's Iain Henderson, and I've been an ophthalmic nurse for 20 years, and I'm going to talk about triage today. So there's only a few emergencies in ophthalmology, so the immediate ones that we need to take account of are sudden loss of vision, increase in pain, whether in the eye or headache or body, chemical injury or mechanical injury, a sudden red eye, or something systemic. And also the most important thing is duration for these, because if something's been happening for months, it's not an emergency. It should be something fairly recent. So the difference between the service you offer will be different from place to place. Now, do you offer a walk-in service? Is it an A&E service? Urgent care centre, referral only? Are patients able to walk in or self-refer? Do you treat minor illnesses? And that really kind of will make a difference to the kind of what you're triaging, what you accept through the door. And this is where it can make quite a difference between what the patient expects and what service you're offering. Now, the problem is if these two kind of don't coincide, the patient's going to be angry, disappointed, aggressive, and it's important to respond to this kind of that. So if you don't offer a walk-in service, but the patient expects a walk-in service, sometimes you can use a wee trick there, and it's about modifying patients' expectations without telling them off. And you can do that by just saying, are you expected? What time is your appointment? We have an appointment slot at 2 p.m. And this kind of just puts the onus back on the patient. It's saying to the patient, well, do you have an appointment with us? Because that's the service we're offering. And then they will have to negotiate that. But always be ready for the unexpected emergency. You will get patients that don't have appointments and haven't been referred correctly, and this means you will have to assess them to see if they need to be seen immediately. What's a good triage system? Now, a good triage system is something where the assessment's been done before the patient arrives. So ideally, somebody that's referring you should use a pre-assessment form. This should capture the visual acuity, and it would be good if they had the eye pressure, because eye pressures can make quite a difference. If you've got a red eye and you know if the eye pressure's up, you'll want to see that patient fairly urgently. If you've got red eye and no pressure, you'll be, well, maybe this doesn't have to be seen. So pressure's important if possible. Also, documentation of symptoms, duration again, you must have the duration on these things. A basic examination of the eye would be helpful on the pre-assessment form, pupils, RAPD, ocular eye movements, and possibly a fundus examination or optic disc assessment. Also, if the patient's had previous eye problems and past medical history. These are all very useful for a triage person to know in a referral. Also, I found what's useful is an email address. So an email address staffed by an admin staff, and what happens there is the senior nurse or doctor would kind of look at these kind of referrals that come in and action them. And this is very useful. So you need to have good pathways into urgent clinics and primary care clinics. And this helps with if you're only running an emergency service, it doesn't get clogged up with non-emergencies or intermediate emergencies. So you can refer them into like a corneal clinic or a primary care clinic. It's also important to have a dedicated senior triage person. They can take telephones, assess referrals and walk-ins, and that means they're not getting clogged up with seeing patients and treating patients. This brings us to a bad triage system. So if you don't have a dedicated triage person, you're going to get everything coming in. There won't be any effective triage coming on. Poor levels of staffing, again, who's going to answer the telephone if you're treating patients and you're just trying to get through everything? Junior staff, I would recommend kind of senior staff to do triage. Junior staff, they're not going to kind of be able to sort out any minor illnesses, non-emergencies. And are you having somebody treating minor conditions? Do you need somebody separate to manage this? If you don't have somebody separate, is the triage nurse going to do it? You're not going to have an effective triage. Also, if you have no ability or capacity to refer to urgent or primary care clinics, that means your casualty, your emergency service is going to be clogged up with non-emergencies, things you're going to have to follow up yourself. Now, the two main types of triage system, you've got a diagnostic-based triage system, and these are kind of immediate emergencies. I haven't got time to go into intermediate or urgent, but generally speaking, you have to have a lot of knowledge to use a diagnostic-based triage system. Now, you need to know what giant cell arteritis is. You need to know what central retinal artery occlusion are. You need to know acute glaucoma, double vision, endophthalmitis. You need to know about chemical injuries, orbital cellulitis. This needs a lot of knowledge and training to be able to operate a diagnostic-based triage system. So this slide is about a symptom-based triage system, which is maybe a bit better to use for somebody that's not experienced in ophthalmology, for somebody that hasn't had ophthalmic training, maybe it works in main A&E or GP surgery. Now, symptom-based ophthalmology, so it's something like, is there sudden vision loss? Is there sudden increase in pain? Is the eye suddenly red? Now, these are much easier to kind of operate by junior staff and easily kind of interpretable. If you kind of contact somebody experienced with just symptoms, they can understand what you're on about and guide you from there. Any kind of chemical injury, penetrating injury, again, that's very important. Any sudden double vision, any kind of illness, kind of flu-like illness, systemic illness with eye problems, again, very important to kind of highlight. So what about triage? Now, an effective triage, I mean, I've done triage for many years, and what do? Ask. If a patient comes in with sudden vision loss, when did it start? How long has it been? Is it getting worse? Pain, when did the pain start? Where is the pain? Just keep asking details about these symptoms. Is your systemic conditions getting worse? Headache, where is the headache? Is it above the brow, top of the head? Is it worse at any particular time? Is it worse in the morning, the day? These are important. It's important to ask details about the symptoms. So past eye problems are important to know when you're triaging as well. The symptoms can make a big difference. If you've got flashes and floaters, generally that might just be a posterior vitreous detachment. But if somebody says they're high myope, have previous retinal detachment, that's going to make your decision a much more acute. That's definitely something that needs to be seen fairly quickly. If they're not an emergency, always double check. Some patients aren't great at communicating, so ask again. Why are they attending? What's brought them in today? Has anything got worse recently? You don't want to miss something just because somebody can't communicate. If you decided they're not an emergency, there's no need to do the vision. Some people say you should all do the vision. Why? If you're not going to treat them, or if you're only redirecting somebody to another service, as long as you haven't interfered with the vision, you just document you've not done a formal assessment and you've pointed them in another direction. And always remember, check the pupils. Pupils are a very, very good sign in ophthalmology. If something's irregular or dilated, fixed, that's very important. It could make a big difference. So if you look at just one example, a sudden loss of vision, this is a central artery occlusion. Always needs treatment within 2 hours of the symptoms. There's not much research on it, but it's a sudden painless loss of vision, white eye. Vision often count fingers, hand movements, perception of light, and you'll have a positive RAPD. You may have a history of kind of transient vision loss. Treatment, well, again, there's not much research there, but we generally kind of try and increase the outflow by ocular massage, CO2 rebreathe for vasodilation, urgent transfer. If you get a phone call with somebody with a sudden loss of vision and it's been 2 hours, tell them to breathe into a paper bag and massage the eye. It could make all the difference to the vision coming back. What's more important, prognosis is often very poor with these patients, but it's more important, it's this systemic condition. Why has this happened? Are they going to have a stroke? Check the blood pressure, check the bloods, and carotid Doppler maybe. It's a very poor prognosis though. And then our famous one, an acute angle closure glaucoma. Now with this, you've got brow pain, you've got blurred vision and nausea. Sometimes it can be missed as another practitioner might be treating them for nausea and vomiting and headache, and actually it's all coming from the eye. You can see here, this is a typical acute angle closure, red eye, corneas hazy, pupils dilated, and they'll have forehead pain and brow pain above the eye that's affected. Other kind of sudden loss of vision, you can get vein occlusion, optic neuropathies, vitreous hemorrhage, retinal detachments. Some of these are not, you don't necessarily have to do immediately, but certainly they need to be seen the same day if the vision is affected. A sudden increase in double vision. Now, I've just put a picture of a kind of traumatic one here, but neurological kind of issues would be more important. So third nerve palsy. But when you're assessing somebody's double vision, it's very important to know if it's monocular or binocular. That will save a lot of hassle. So if you cover this gentleman's eye, if you cover either eye, their double vision will disappear. If it's monocular double vision, the double vision will stay depending on which eye is affected. It could be both. So double vision should disappear if you cover an eye, and it's binocular double vision. And it's far more urgent binocular double vision. Chemical injuries. Now, the most important thing about chemical injuries are, first of all, did they ingest or inhale anything? That's the primary concern, because any kind of workplace chemical injury means there is a high risk of ingestion and inhalation, and that would need to be treated first. If there was any airway problems, they may need to go back to A&E, they may need to go to intensive care. It's important to know how long ago it was and how much irrigation was done. Was it alkaline or acid? And you can see in this picture there's a white patch, which means there's bleaching. So these kind of vessels have become ischemic. Ischemic vessels are a bad sign in a chemical injury. And here we have got a picture of a red eye. So red eyes are sometimes the most difficult to diagnose. And this means history becomes very important. Is the photophobia? Is the other eye red? Any sign of upper respiratory tract infection? Any headache? It could be anything, a red eye. But one of the most important things are photophobia and is the pupil irregular, dilated, and that's gives you a very good sign of what's happening. And then here's another kind of red eye with a kind of dilated pupil. Looks like this has been happening for some time, but it certainly kind of highlights the kind of point that you must check the pupils, and that gives you a good sign of what's going on. One other thing is just don't be distracted by red herrings. So I had a patient that came to me. He was doing some bathroom renovation, putting some ceramic tiles up. He came in and said, "Oh, I've got to put ceramic tile in my eye." I looked at the eye. It's like certainly had a kind of localized area of kind of fluorescein uptake, and I'm like, "Oh, but there's something else going on." The blood vessels were a bit dilated. He had a bit chemosis. It didn't sit right with me, so I was I had to be a bit careful because the patient was telling me one thing, and when I looked at the eye, it was telling me another thing. So I kind of had another look, and I noticed he had a proptosis. So he ended up having an AV fistula. So patients that come and tell you a story, you have to be a bit careful. Careful of them self-diagnosis. You may have a lot of patients that come tell you they've got an infection. We're not treating diagnoses, we're treating symptoms. It's important to know what the symptoms are rather than the diagnosis. And that's my presentation finished. I hope you enjoy it. If I could recommend that, actually, if you want to learn triage properly, it's going to take more than 12 minutes. So you need to spend a good day doing triage. Okay, I hope you have a good day today, and thank you very much.